All right, we already talked about this. Cafe au lait spots, leash nodules, iris hematomas, cutaneous neurofibromas, pheochromocytomas, optic gliomas. What's the most likely diagnosis?
Neurofibromatosis.
Neurofibromatosis type 1, right? Neurofibromatosis type 1. A patient with calf pseudohypertrophy. Calf,
Oh, Ducrectic, Ducrectic,
what did you say?
Ducrectic, Duchenne,
Duchenne. Good.
Duchenne. What is Ducrectic? One second. I think that all the information is a mess in my head.
Yeah, that happens. That's fine. So that would be Duchenne's muscular dystrophy, right? Duchenne's muscular dystrophy. What is the gene that is involved in Duchenne's muscular dystrophy?
Mm,
What's the gene that is involved in Duchenne's muscular dystrophy?
I don't remember.
The dystrophin gene, no? Right? That will be the dystrophin gene. And you want to remember here that the first set of muscles that are affected in Duchenne muscular dystrophy are going to be the muscles of the pelvic girdle.
Mm.
Remember that information. The muscles of the pelvic girdle, so your gluteus maximus and minimus and those guys. Do you get that? And then it progresses upward and whatever. Now, however, these people have calf pseudohypertrophy, classic finding. And if you did a biopsy of the calf, what are you going to find?
Red,
Not red ragged fibers. Nope.
red
Okay.
rabbit.
But now that you mentioned red ragged fibers, we'll talk about that briefly. You see fibrofatty changes or fibrofatty replacement of your hip muscles. Oh, did I say hip? Of the calf muscles. Okay. So instead of having muscle tissue, you're going to have these fibrous, fatty tissue right there. As a result of all these changes going on in the lower limb, this child finds it difficult to stand, right? From sitting position or whatever. What do we call the sign that they present with?
Gower.
Goer's sign. They would present with Goer's sign. I was going to ask you a question. And of course, they are going to be walking abnormally, right?
Mhm.
Okay, you mentioned something and I was going to ask you about it. Red ragged fibers. Tell me about this.
So what I know is mitochondrial
Perfect.
inheritance
Mitochondrial inheritance or
and
mitochondrial diseases, right?
and and because they have three types of presentations.
Okay.
And that's it. I don't remember what else can I do. It's the melan, something like that. No?
it's that.
Okay, so there's MELAS, right? There's MERF,
No, it's really warm, man. Warm,
and there is what? Leber's optic neuropathy.
warm like
Leber's optic neuropathy. So this was mitochondrial encephalopathy with lactic acidosis seizures, right? And this was mitochondrial encephalopathy with red ragged fibers,
Yeah.
right?
Yeah.
All right. What to be increased in these patients? In people with, I should say, Duchenne's rather. What is increased in the blood? Increased creatine kinase and what?
Adolescents.
Aldolase. Very good. You want to remember that. All right, they give you a patient with cervical lymphadenopathy, discriminating rash. Cervical lymphadenopathy, discriminating rash, coronary aneurysms, red conjunctiva, and tongue. Cervical lymphadenopathy, discriminating rash, coronary aneurysms, red conjunctiva, and tongue. Most likely diagnosis. I would give you a
Is
bonus if
Kawasaki?
you could. Perfect. Kawasaki disease. Kawasaki disease. How do you treat Kawasaki?
We treat with aspirin.
Aspirin
Yes,
or an
sir.
IV immunoglobulin. This is one of the few places where you can give aspirin to a child, right? One of the few places where you can give aspirin to a child. Otherwise, what does aspirin cause in children?
Rare disease.
Rare
Rare syndrome.
and it's basically destruction of mitochondria, right? You remember that. All righty. In people with Kawasaki disease, what sometimes we talk about the strawberry tongue. We talk about the strawberry tongue. Where do you have strawberry cervix?
Oh, yeah. We have in Pneumonia.
Trichomonas vaginalis.
Yeah, I mean,
What do you see on microscopy for Trichomonas vaginalis?
We see
Motile organisms.
group cells. No, what's it?
Remember that they have flagella, right? They are flagellated and they can basically swim with their flagella. You remember that?
Yeah.
How do you treat Trichomonas vaginalis?
Metronidazole.
Metronidazole. What's the mechanism of action of metronidazole?
They destroy the DNA.
They destroy the DNA, yes. How?
They produce efflux.
They produce free radicals and destroy DNA, right? They produce free radicals and those free radicals destroy DNA. Do you remember the side effects of metronidazole?
So yes, well, they have the different effect.
They have what?
Diffuse
Oh,
disulfiram.
disulfiram-like reaction. And what else?
Metallic taste.
Metallic or bad taste, right? You don't have to say metallic.
Okay.
Metallic or bad taste. That was metronidazole. I was going to ask you a question on something. It skipped my mind now. Which of your antifungal drugs cause disulfiram-like reaction? And of course, disulfiram-like reaction is when used with alcohol, right? Remember that?
Yeah.
Yes, tell me.
Is the azoles?
No, that would be griseofulvin.
Fluconazole.
No, griseofulvin.
Griseofulvin. Yeah.
Okay. Griseofulvin, not the most important thing, but it's a thing. You want to remember that. But that's not the question I was going to ask you. And since we are talking about disulfiram-like reaction, let's briefly look at the pathway for alcohol metabolism. When people take alcohol, what is it metabolized into? And by what enzyme?
Alcohol dehydrogenase.
Alcohol dehydrogenase. What is it metabolized into? The aldehyde form. And then the aldehyde form is metabolized what? Into the carboxylic acid form by what enzyme? The aldehyde
Oh, yeah.
dehydrogenase as well, right?
Yes.
What do we call it when people have a deficiency? We said it was the aldehyde that was responsible for hangover signs, right? Headache, flushing, and all of those things. What do we call the condition where people have a deficiency in aldehyde dehydrogenase? A deficiency in aldehyde dehydrogenase.
Is it super?
What do you call it?
Uh,
That was Asian flush syndrome. If people with this deficiency take alcohol, they're just going to have very bad or very terrible headaches, flushing, and all of that. You get it? Okay, and then when medications sort of interfere with the activity of aldehyde dehydrogenase, they produce disulfiram-like reactions. And that's that. When people overdose, we have two types of bad alcohol before we even get here that you need to be concerned about. What were they?
Methanol, ethanol,
Methanol and what?
ethanol.
No, ethanol is the regular
I
stuff.
don't know.
Ethylene
Oh,
glycol,
guys,
right? Methanol and ethylene glycol. What does methanol cause?
blindness.
Blindness, visual abnormality, and ethylene glycol, maybe metabolic acidosis, right?
Yes.
And all that stuff. So if someone takes either of these things, what's the medication we give to them that can inhibit alcohol dehydrogenase and prevent the metabolism?
Flumoxyl.
What did they call it?
No. Start with flu.
Start with F.
Flumoxyl.
Okay, but not quite flu.
For.
Mhm.
Oh my god. Fomexy.
Fomepizole, right?
Yeah.
And you want to remember that this alcohol dehydrogenase is a P450 enzyme. It's a P450 enzyme. So fomepizole technically is a P450 inhibitor. Does that make sense? So fomepizole here is a P450 inhibitor. Do you get it so far?
Yeah.
What medications can we use to decrease craving in alcohol patients that want to stop drinking alcohol or to induce aversion? What would it be? Well, to decrease craving, we should talk about first. To decrease craving.
I don't remember.
You remember naltrexone?
Oh, yeah.
And the second medication I just skipped my mind. So naltrexone is the big one. There's the second one that I'm not remembering. Acamprosate. Okay, there you go. Naltrexone and acamprosate. What's the medication that we can use to induce aversion? So if they have an uncle that likes taking alcohol and disturbing everybody in the house, and we want to give him a medication so that when he takes that medication, it would inhibit his aldehyde dehydrogenase and elevate or increase his hangover symptoms, and he will stop taking alcohol. What do we give him? Disulfiram. This is why we talk about disulfiram-like reaction. So disulfiram will be that medication. Do you get it?
Yeah.
If they give a patient with cherry red spots on the macula,
I'm thinking about Sasha.
you're thinking about what?
Sasha, something like that. It's
Tay-Sachs disease, right?
yeah.
You think about Tay-Sachs disease. What's the second one? There are three of them, right?
Pneumonia,
B. And what?
cytomegalovirus, maybe?
Why do you like cytomegalovirus so much?
I don't know.
Okay, we'll talk about CMV after now, a little bit about CMV. Tay-Sachs, Niemann-Pick, and what? Central retinal artery occlusion.
Yeah. I just worry that the black hole, like,
Central retinal artery occlusion, right? Remember that sometimes they may describe cherry red spots on the macula as bright red fovea centralis. Bright red fovea centralis. Do you get that? They may describe cherry red spot on the macula as bright red fovea centralis. What's the enzyme that is deficient in Tay-Sachs disease? What enzyme is deficient in Tay-Sachs disease?
It's the low.
Hexosaminidase, right?
Oh yeah. It's a samidite.
And what was accumulating?
The GM2
GM2 ganglioside. Very good. What was special about Tay-Sachs when you compare it to the other lysosomal storage diseases? What was special about Tay-Sachs? What did they not have for the most part?
The developed delay.
No, they have no hepatosplenomegaly. You remember that?
Yeah.
They have no hepatosplenomegaly. What was deficient in Niemann-Pick's disease?
That is the sphingomyelinase.
Sphingomyelinase. And sphingomyelin was accumulating, right? It's pretty simple. And then we have central retinal artery occlusion. What could cause central retinal artery occlusion?
A clot.
A blood clot, atherosclerosis, right? An atherosclerotic plaque or something like that. Okay, let's talk about CMV for 1 second. What kind of patient are you concerned about may have Cmv pneumonia?
Immunosuppressed.
Hmm?
Immunosuppressed
Immunosuppressed.
patient.
On the exam, there's a type of patient they always ask related to CMV. Transplant patients. Oftentimes renal transplant, right? You remember that?
Yeah.
People with CMV may have mononucleosis-like presentation. How about congenital CMV? What do you see around the ventricles?
Oh, ventricle septal defect.
No, not the okay, not ventricles. I mean ventricles in the brain.
Oh, they produce hydrocephalus.
Maybe periventricular calcifications is what I'm looking for. You should be thinking of hydrocephalus in relation to toxoplasmosis, congenital toxoplasmosis. Do you remember that? Not really. Okay, so you should look that up immediately we finish, right? Periventricular calcification in CMV, CMV pneumonia in renal transplant patients, CMV esophagitis. Which kind of patients get CMV esophagitis?
What kind of patients? HIV?
HIV patients, right? They can get herpes esophagitis, CMV esophagitis, candida esophagitis, of course, right? When you get to step 2CK, you start talking about the order in which you suspect them. So if a patient has HIV and they have dysphagia, for example, you know, okay, your biggest suspicion is candida esophagitis. You treat them first. If they don't get better, you do endoscopy, whatever. So those are not going to be very useful for you. But congenital CMV, we talk about periventricular calcifications will be useful. How do you treat CMV?
with Carnet.
Okay, first canet, what will you pick as probably first line? Gancyclovir. Right? So we have gancyclovir, we have first canet, we also have cidofovir. What did we use for HSV?
For HSV, we use Cidofovir.
Nope. Acyclovir.
It's actually
They all they all basically have the same side effect, the same mechanism of action rather, right? What was their almost universal mechanism of action?
They inhibit DNA polymerase.
Inhibit DNA polymerase. But gancyclovir and acyclovir, gancyclovir and acyclovir required the viral kinase for activation, right? Gancyclovir and acyclovir required the viral kinase for activation. So the mode of mechanism of resistance against gancyclovir and acyclovir is simply a mutation in the viral kinase.
Okay.
Right?
Yeah.
Whereas phosphonate did not require viral kinase. And so the mechanism of resistance against phosphonate was what? A mutation in the DNA polymerase itself.
Okay.
Do you remember? Do you get that?
Yeah.
With cidofovir, what medication did you give to reduce the toxicity of cidofovir or prevent the renal toxicity of cidofovir?
Probenecid.
Probenecid, right? Probenecid and saline. Do you remember an anti-cancer medication that we gave amifostine and saline to also prevent its nephrotoxicity? An anti-cancer drug, we gave amifostine and a lot of fluid and saline to decrease its nephrotoxicity. That medication also caused ototoxicity.
Methotrexate.
Nope. But since you mentioned methotrexate, we'll talk about methotrexate in a bit. What was this medication?
I don't remember.
This was cisplatin.
Oh.
Cisplatin. Cisplatin causes nephrotoxicity that can be prevented with amifostine and saline. And of course, it also caused ototoxicity. What was the side effect of methotrexate? You have your anti-cancer template as well, anti-cancer drugs, anti-cancer medication templates. I sent you all of those, right?
Mechanism of action from methotrexate. Okay. They inhibit the EMP.
They inhibit what?
EMP. I don't remember.
IMP?
I just found the purines. The purine.
Purine synthesis? Nope. We had purine and we had pyrimidine. Methotrexate was on this side, on the pyrimidine synthesis pathway. IMP dehydrogenase you're talking about, if you remember, was mycophenolate and ribavirin. I think there's one other medication, mycophenolate, ribavirin. No, there's no other medication. So it's mycophenolate, mofetil, and ribavirin. Mycophenolate, mofetil is one medication. Then on the pyrimidine side was where we had methotrexate. So what enzyme was it inhibiting? And methotrexate, pyrimethamine, right? And I think sulfamethoxazole, if I remember correctly, were inhibiting the same enzyme. What was it? Dihydrofolate reductase. You remember that?
Yeah.
dihydrofolate reductase. And by so doing, these guys, oops, this is wrong. Trimethoprim. I think that's the correct. So methotrexate, trimethoprim, and pyrimethamine. We are inhibiting dihydrofolate reductase, right? And by so doing, these guys are inhibiting B9. So when we gave methotrexate, what are you supposed to add to prevent bone marrow suppression? What did we add when we give methotrexate to prevent or reduce bone marrow suppression?
Folate?
Folate in what form? Folinic
Folic
acid
acid.
or leucovorin, right? So side effects of methotrexate now. Let's talk about the side effect quickly. Side effect of methotrexate.
Suppression.
Okay, everybody causes bone marrow suppression, so it's unlikely they will ask you about that. What else?
Perfect.
Pulmonary fibrosis, hepatotoxicity, right?
Yeah.
It caused all of those things. Give me other medications that cause pulmonary fibrosis. And we should finish with these guys for today.
Fibrosis.
So we talked about methotrexate. What else? You remember bleomycin?
The one that starts with the
That starts with what?
A.
With A, amiodarone.
I mean, I like the
Right? These
Yeah.
medications will cause pulmonary fibrosis. Do you have any questions?